Welcome to the Anatomy of Therapy. I'm Dr. John Cybulski here with Bobby Riley. Today, we are telling jokes to start this thing off. We are in good spirits. We are laughing. We are jovial. But more importantly, we're going to get into rehab. What with rehab? Great question, listener. The rehab we're going to get into today is some traditional rehab. Like, what are the standards for rehab? What are some of the old school methods of rehab? What are the principles behind those? What do general people give for rehab today? And perhaps what are some of the benefits of general, traditional rehab? And perhaps what are some of the holes? What are some of the gaps that some of this kind of old school rehab might miss, and what we could do to better that? But first, let's talk about where kind of generally rehab is today, what people kind of think with rehab. I mean, I guess the place to start with this, Bobby, is probably, something straightforward with pretty linear guidelines, like an ACL reconstruction, like a post-surgical thing where there are mile markers. We need to see X amount of range of motion. We need to retest strength being this and that. That seems pretty clear and straightforward. Yeah. What is that? I think that's the most obvious way to kind of start here. What is the clearest objective part? And that, like an ACL, when you think of an ACL, let's just stick with ACL rehab, like what pops into your mind in terms of the rehab for it?
Well, I'd say, something like ACL reconstruction has so much money and importance behind it that it definitely gets, raised to the top of priority as far as research goes, because, these are your quarterbacks in the NFL. These are your, the soccer players and tons of youth sports athletes as well, but big names, big money, lots of these injuries, very, very common. So it has a lot of research behind it. And so what that means is we may not have it all perfect yet, but it's constantly being studied and upgraded and a little bit of nuance. And I was fairly up to date for a while with some of the Andrews Institute stuff, but I couldn't tell you, in the last year or so what the main research is saying. But, like with those, they have these like you were saying, milestones, these mile markers that you have to hit. When I was working more with sports, it was, making sure that they had mobility first. Like I was, you could always get that strength back, but you can't always get the mobility back after some of these surgeries.
Sure.
So, making sure that that you can get full knee extension again, and you can get full knee flexion, and you get some rotation in there, and then you start to build up some strength, and then you have these progressions that we all know, going something from isometric, maybe something less inflammatory, towards something more eccentric to concentric, and then you're doing full range, and then you're doing stuff that's more dynamic. And like the Andrews Institute, for example, has a lot of this stuff laid out. And I think most physios and physical therapists and maybe the few chiros that do this kind of work, they follow that to a T. And, we've seen in the last maybe decade where ACL return to play has gone down from something that was closer to 12 to 14 months to, man, some people are back in 5 or 6 months, which is kind of crazy.
Mm-hmm.
But like the point of all this is that I would say that you were alluding to is there's closer to an objective science to recovering an ACL. But then we really quickly fall off in how well we know and how well we've studied, and we really have a grasp on things like low back pain, and non-specific knee pain is not really a thing, but it should be, because we don't always know the diagnosis, and we don't always, or at least we're not always smart enough to figure out exactly what it is. And that stuff we fall off fast on. And I do think that is part of the problem, right? Where there is this variety, and that's why there's a million Instagram accounts with a million different things you can do. And that's because it's kind of fair game, because we don't understand everything. There's still camps arguing about stretching. There's still camps arguing about stability exercises versus just, go barefoot and climb trees. And there's just all these different perspectives, and they're out there because we don't have it all figured out, in my opinion.
Right. No, I mean that's true. But okay, so let's kind of bring this back in. That's the wider idea of it. When let's just go to a general back pain. You go to a physical therapist, a general physio, nobody that's a necessarily a specialist. Let's say you went to your family doctor and you had low back pain. Uh, Actually, let's start with the family doctor, because oftentimes the family doctor will give you a printout of some great stretches and exercises to do that they got from an orthopedic seminar in what looks like 1992. With the patients that have brought me these handouts, it's like lay on your back and kind of hug your knees. Um,
Mm.
Sit, cross your leg into a figure four position and push your knee out a little bit. Very passive, very mild. It's more so this idea that, it's going to heal. Give it 6 to 8 weeks, and the injury should heal. Here's some muscle relaxers, perhaps some opiates in the meantime. I know that's going down quite a bit with doctors these days, thankfully. But they will give them some general stretches. Where does that come from? Like, let's just say start with that mentality. The MDs, I know they're not necessarily musculoskeletal specialists, but like a family doctor, they just have a printout of the, what is it, like 12 best stretches, exercises. They might give them a clam or a glute bridge. Where do you lump that kind of thinking in with?
Well, I do think it stems a little bit from what I said before, where we don't know everything for sure, but the incentives for somebody like a medical doctor are not there for taking the time to establish the correct, rehabilitation exercises for a patient. They don't have time. I think the average is 7 minutes in the United States with a
Right.
person. I mean, and I know Stuart McGill's first visit consultation is 3 hours.
Crazy.
So you have 7 minutes or 3 hours, and there's a big difference in what that yields. And I know I've mentioned McGill on the podcast before, but he was somebody when I was in school that opened my eyes to whether it was medicine like you're discussing, or chiropractic school or physical therapy school. We were taught certain things. We do this for rotator cuff tears, we do this for low back pain. And then it was somebody like McGill that made me realize the nuance of the individual. So it was
Right.
through McGill that I first realized, okay, when you say you have a back pain, well, can they handle compression or not? Can they
Mm-hmm.
handle torsion or not?
Mm-hmm.
Can they handle flexion or extension or not? You see what I mean? They that that if you can't handle shear or rotation, well, then a Palloff press is not your answer. Even though in many websites or Instagrams or YouTube, it'll say for low back pain, try a Palloff press, or for core control or core stability,
Mm-hmm.
do a bird dog. But you have to establish whether or not that individual needs that type of rehab. And in medicine, there's no chance that they're going to do that. I mean, I think I don't. I mean, they are brilliant at what they do. But that's not what they do. They don't spend
Right.
time. They usually don't touch you. But the amount of, what do you say, rote memorization and knowledge that medical doctors have, to me, is kind of mind blowing. They work very hard. They spent a lot of time, but this is not an area where they're specialists in, and that's why it's a little weird, this portal of entry where people go to the medical doctor first for things like, a 3-4 out of 10 knee pain, that kind of messes up their running a little bit. I mean, and I do think it's kind of ridiculous that physical therapists in some states still require a doctor or an MD referral. That doesn't make any sense to me either. So,
Right. No, I think some of even the words I think you were using that McGill uses to describe pain, like torsion, compression, I don't think that MDs even have those floating around in their mind in terms of low back pain. They're like, is it a disc? Are there neurological symptoms? After that, it goes very far. Like, there's inflammatory process going on. But some of the words that you used, and we don't want to get into like Wittgensteinian philosophy, but you are hindered by your language
mm,
in these terms. And so a lot of MDs legitimately, and again, they're fantastic at reading a blood panel, where I would be googly eyed and have no idea what to do. But in terms of low back, there are so many other factors that you can consider. I do think those exercises that they give them, the basic, stretch your hamstrings, reach down for your toes for 10 seconds and then come back, are perfectly appropriate within their realm of what they understand about the back. Okay, so that's that step. Let's move on to the next one. You are hindered by your language, expand your vocabulary. That would be cool. The next step is there's an MD. He goes, I don't know what's going on with his back. I've been dealing with these crazy people who come in and tell me that they've got this disease that's going on in the world, but I will probably just refer you to a PT. And let's just say you're in one of these crazy states that tells PTs that they have to abide by what this doctor, who is immediately limited, now you have to follow what I've said to do. But let's just say you're a DPT or something like that, PT, DPT, or physio, perhaps in another country, and you get one of these referrals from an MD. Now, let's just say you're a general PT or physio, and there's 12 of you in the clinic, and you've got a bunch of people coming in. The general rehab isn't, as far as from the PT and physio experience that I've had, again, generalizing, hasn't been very specific or nuanced, where they will check the straight leg raise. Is it 65 degrees? And once we can get you to close to 75 or 90, there are some of those standards for back pain. But again, they're still kind of limited by what the MD kind of tells them. When you think of a generalized PT kind of going after these things, maybe you can just tell from like your patient experience, what do patients that come to you after seeing a PT kind of experience in these general PT kind of farms for back pain? Let's stick with back pain in the rehab.
I mean, I would agree with you, and I'm not trying to throw that profession under the bus, because we could do the same thing with chiro as well, for what we say would be the stereotypical kind of predictable standard of care coming from those communities, right? And of course, there's just brilliant physios and brilliant PTs and brilliant chiros out there that are, always thinking deeper about things. But I mean, yeah, when you just say the kind of run of the mill, or we'll just, to be nice, we could say the new person out of school as well,
sure,
just doesn't know any better. I've kind of seen these multiple pages stapled together where they come in, they say, well, my back still hurts. That's why I'm coming to see you now. I thought I would try something different. Come in and I say, okay, well, what are you doing? Can you show me what the physio or the PT gave you? And they give me these 3 pages, and I'm flipping through, and it's like, okay, there's planks, and there's bird dogs, and then there's stretching, and then there's more training. And then for some reason, there's like shoulder exercises in there. And you're
yeah.
Okay, this is like full body training. This is kind of playing darts in the dark, as I like to say. Yeah. It seems so broad and so sweeping. It's the roller brush for painting the wall, right? It's not the fine brush. It's not it's not the specifics. And that's because if you don't have the tools, or you don't have at least the mental faculty, or let's say your, not strategy, but the process of going through a patient, then it's kind of irrelevant again. Like, right, you don't know the process to go through to weed out what makes a good exercises and a bad one, or a good stretch and a bad one. So you just throw out many things at them. And that, I have seen that come in to the clinic many times.
And I mean, I think the reasoning behind it too, like because I've got these people that are brought in, they're like, this is my rehab for my back pain. Still there. I saw these PTs for 18 visits, and I'm like, wow, you were patient. You stick around for all these visits. But I think the idea behind this kind of the roller painting, or I don't know, might even be a spray paint, they're just blasting out a wall, is trying to see what sticks, basically, because maybe it has stick before. That they need to get their glutes to work. We know that we need to take strain off their back. They say their hamstrings are tight. They have a straight leg raise that needs to be fixed. They're kind of going off some of these orthopedic tests, and this is their best guess as to how to fix that, basically. Some of them will just, I know that there's a lot of like seated bike riding for whatever reason, my patients will tell me. And it sounds fun to sit and ride a bike, but I wasn't exactly sure how that helped their, L5 iliolumbar ligament sprain strain. But anyways,
Mm-hmm.
but I do see that there is a logic behind the exercises they give. I don't think these, say, new PTs, or honestly either new PTs or very old PTs who are just kind of a little bit stuck in their ways or don't know any better and are doing the absolute best that they can, are trying to throw everything at this patient and just pray that something sticks. I'll say this is kind of where I think it gets a little bit interesting for me. I can appreciate being like, do clams on the left, do clams on the right. Do a bridge over here, do a stretch your quads and stretch your hamstrings. Let's do a pigeon and stretch your glutes. And we're going to do some ice on your back, plus 12 other things, planks, stuff like that. I can appreciate them trying to do all these things, but then I think about it from a patient's perspective, and it's like, I've got 46 things to do for this. And honestly, I feel like compliance with these things is going to be pretty dang low. Do you know what I mean?
Mm-hmm.
Unless they're doing it all there at the PT place, unless they're going to see the PT 3 times a week, which sometimes they are, to be honest, then they're doing it all there. And even in my mind, if you're going to be doing those simple exercises under the guidance of a PT or a PTA, let's just say, could we not be doing something a little bit more nuanced for the patient? Do you know what I mean?
Kind of. But I do think that might be the one scenario where I think throwing many things at them would be beneficial, which would be that one-on-one, because it's that idea. If you just get people stronger, like sometimes I just send people to a good personal trainer because they just need an overall uplift in fitness. And then I have somebody that I trust that can spot a few things, maybe not so clinical things like we can, but knows how people should move, knows how they should breathe or twist, or what there might be lacking and what to look for, how to control pain triggers and things like that. And man, just so many things would go away. So if you have that kind of setup where they come in and you at least get to watch the bird dog, and you can cue them on things and say, squeeze here, not so high with the legs, see how you're arching your back here, can you feel this muscle now? Yes. Okay, that's at least awesome, because you're actually just bringing up the person's capacity, and that alone has a decent shot of helping. But do all these 12 things at home, I don't really like that at all. And one of the main reasons also is because scientifically that's not a great process for you to ever understand what worked for your patient. Like I will say a lot with patients, if I give you 5 I don't prescribe medicine, but if I give you, it's easy to understand. If I give you 5 medications and you start puking blood, like, I don't know which one of those was the problem, or all of a sudden you are relieved. I don't know which one helped you. What you need is you need to do one at a time, or you do one and then you have a control group or a placebo, right? That's how these things work. And that's how you just establish what works. So as a clinician, I would kind of lose my mind never understanding or never really knowing why the patient got better. Because like, I don't know, I gave them 15 things and they're better. I don't really know why. I have always wanted to know why, as much as you can anyway.
Yeah, you can't really know why. And I did in the beginning, you need to start doing stuff, that you have to do something. You can't just play the one by one game. You have to do the best thing that you know to start off with. Absolutely. Okay, so let's just say you're not giving them 15 exercises. You're getting close. We're getting a little bit closer to like an ideal situation where maybe you're I think the step down, honestly, from that position to the next one would be something closer to what we said a second ago with the MDs, widening your vocabulary, having a little bit more, giving the body a couple more capacities. You brought up capacity in general in terms of strength and stuff, but giving the body some further capacities instead of saying you need to use your hips, or rather you need to lift with your legs, right? You've heard this. Maybe we talk about a hinge after that. You need to hinge your hips. And then another level might be, instead of hinging your hips, We need you to shift one femur back, access your posterior inferior capsule at the same time, and keep your hips centrated. That would be kind of another next level where you would add some vocabulary with all of this, and then you would have a different way to attack it. So I think the next step down is to, beyond vocabulary, is probably testing a little bit more differently and seeing those tests a little bit differently. And I'm going to put you on the spot here. I know that you do a lot of testing, and I know that you dig in a lot with your patients. What were some of the tests that kind of opened things up and helped you go kind of to that next level of rehab? Does that make sense? Like, what were you were doing? I know you do a toe touch or you do a straight leg raise. I'm not saying you ignore the traditional orthopedic tests. Were there any perhaps even orthopedic tests that you maybe saw in a different light that helped illuminate?
Yeah, I mean, I can think of many different scenarios, and all credit to the people that I learned these from. Some were from my, I could say my mentor or the first person I worked with thought of things a little bit differently. Things like we've talked about in the past, people like FRC, using things like cars to actually test somebody to know how a joint moves or whether or not it's coming from the joint or from soft tissue. People like McGill, who said, okay, it's not just a straight leg raise now. Okay, do they have any under or over hooks of the nerve root? So let's keep the head and the foot up, and then let's move just the head down or just the leg down and see if they get a little catch. Taking, just taking the nuance of these things much deeper. I mean, McGill was my first introduction to doing that, like I mentioned earlier. And then you're saying, okay, how many other ways can we look at this? And then I would say that, the PRI folks have an unlimited amount of testing that has totally rechanged the way that I see a patient on the table. And they're opened my eyes to things mainly to do with comparison of front to back or left to right or top to bottom, these type of things that help you see things that are not just straightforward. Okay, they have tight hamstrings. Okay, what do you mean by tight hamstrings? Do you mean tonic? Do you mean actually short? And do you mean both of them are equally as tight? It's not one that's tighter than the other. So, and FRC, again, they go into this as well. Is it mechanical tension or neurological tension? All these things, when they tease out, I think, maybe you can touch on DNS a little bit, but there's a lot of different of these, ways of thinking. And people like Shirley Sarman, I read her books, and there's these, these ideas of, well, when a straight leg raise, a prone leg extension, can be something, well, if they're not getting any glute recruitment, the femur actually slides anteriorly, and you're going to get some anterior capsule laxity. There's so many different things that come from, all the different people I've learned from that help me tease these things out. And sometimes one doesn't always work, so you have to, that's why it's good to have a variety of these tests.
Yeah, that's awesome. I think, a couple of the vocabulary within that last 3 minutes was phenomenal. If people had, I wish we could carry on the conversation with a couple of those and just dig into them. But I think the first big step after, because it's usually, this is tight. Let's just vocabulary to start off with. My back is tight. My hamstrings are tight. Let's stick with your hamstrings. My hamstrings are tight. I just can't move. It's not strong. Something pinches, and so as a therapist, you are going to mimic those words as well. But can you dissect tightness to just be, what do you mean by tight? More left, more right? Is the tightness the same on the toe touch as it is on the straight leg raise, right? Versus the seated toe touch. And I'm talking about a little bit more FMS. That was probably my initial jump into the next phase, where they just basically, or SFMA, and this would be, Charlie Weingroff really, really digs into this if you want a good resource for it. And he's been posting some really good videos lately where he talks for about 10 minutes on just kind of where he's at these days. It's pretty fascinating stuff. But the adding the three categories of, okay, maybe it is a soft tissue tension. Maybe those hamstrings are tight just because the soft tissue is tight. Perhaps it is a neurological tension. In other words, they are tight because of a larger neurological compensation in terms of the position of their hips and their hip flexors. Is it a joint problem as well? Could there be a capsular problem in the way? Is there something wrong with the knee if the ACL is jacked up? Those hamstrings better be tight to protect that knee. And so just giving it those kind of three extra little things. Is it soft tissue? Is it a neuromuscular problem, or even just a joint problem? And you were talking about that with the FRC. The CARS guys do that with the CARS testing. It kind of does that really well. And so it kind of lets you know, okay, so if I was to find a neurologically tight hamstring and I give them a soft tissue input, in other words, I say, stretch your hamstrings, put a lacrosse ball on your hamstrings, foam roll, Theragun your hamstrings. And that input gives them a sensation in their hamstrings, and maybe they can touch their toes a little bit better, but then it kind of comes back. That tells me that there's more of a neurological thing, but it just kind of broadens that horizon just a little bit. And it also helps me kind of with my input into what I should do next. Does that make sense? Well, with these backs, some of these things can be a little bit tougher to explain to patients. So that's more of the doctor side. Let's switch back a little bit to the patient side. And let's just say your McGill example of the overhooks and underhooks, with and I know he gets to spend 3 hours with a patient, which is a dream world for me. But how does it translate when you try to describe some of these things to a patient in terms of, how do you explain that to a patient? Because I can say this hamstring is tight because it's just tight. This hamstring is tight because of a more global problem. That seems pretty easy, but how far and how deep do you go into that with your patients?
Well, I definitely would go into it on something like a tight hamstring for somebody who has a disc problem, because if the care that they were given or the program they were given was around stretching out that hamstring, and you can sit down and talk to that patient and say, listen, you've been stretching your hamstring. How much has it helped? Well, it maybe helps for a few minutes, and then actually later it actually feels worse. Okay, and then that's the impetus for you to go in deeper and explain why, not just telling them something's wrong, but you can just feed off of their own words and say, I can kind of explain that to you. When you're trying to stretch your hamstring, there's not many easy ways to stretch your hamstring, to be fair, without putting some kind of low back pressure. And stretching your hamstring pulls on the pelvis, and the hamstring is tight, not because it's tight, it's just reacting to the disc. So I talk about this protective mechanism that the body does. And most patients, I think, get that. I say this hamstring will go back to whatever your normal flexibility was prior once your back feels better. Trust me. So then I'm like, don't worry about stretching the hamstring. Let's worry about the irritation that's going on in your back, because that's what tells the brain that hamstring needs to stay tight in order to stabilize you and to keep you from, over bending, which is kind of the main reason it's there. So you don't go touch your toes and irritate the disc more. And I do think, you can see this nuance where people think, okay, if you have a sciatica or you have referred or neurological symptoms down the leg, that you should do neural flossing. Well, sometimes neural flossing makes it much worse. It's if you have an entrapment of the nerve and you're trying to kind of, or pressure on the nerve, and when you're yanking on it, all you're doing is, it's like, and it's a terrible analogy, but I say you're standing on the dog's tail, and the dog can't get away. It's trying, and all it's doing is hurting itself, because as it tries to get away, it's squealing more and more because you got so much pressure. But if the tail actually can come free, which would be synonymous with something like the nerve is now gliding better, you'll see them, they'll do their flossing, and then all of a sudden their straight leg raise goes up, or their back pain gets less, or their leg pain goes away. So this is where, okay, is flossing good for sciatica or disc symptoms? Completely depends.
Right.
Completely depends. And sometimes you have to test it to find out. Same with McKinsey stuff.
Yeah.
Some people, you put them prone on the table and they can't even get up, and then you're going to have to carry them to their car. So it would be terrible to prescribe McKinsey. So you always have to test these things.
Yeah. No, I think that's a great explanation. The real reason we did this, the question we started this podcast with, is what does it take to make a change? How much rehab does it take to rehab into a change? And if we go all the way back to the very beginning, those MDs are kind of just hoping for that 6 to 8 week window for the body to heal, the very general do some activity, and here are some some meds to kind of get you along. Same thing kind of goes for generally with the PT, and traditional chiro. We'll make sure we'll throw them in under the bus a little bit too, because if you're going to treat me for 6 to 8 weeks, that natural injury is going to kind of heal. Is the question that I am thinking about constantly, personally, on a day-to-day basis, on a patient-to-patient basis. What rehab, how much rehab, what specific rehab is it going to take to make a change that matters for this patient's condition? So there was a great quote I saw literally this morning on Craig Liebenson's story. I believe it was from somebody else, but he said basically that rehab is training under the condition of pain. So for instance, going back to your example of the back hurting with the McGill thing, is it provoked in flexion, extension, and compression, in twisting, in torsion, and in a combination of those sort of things? So a lot of times I am looking for say the painful segment, like the lumbar spine. It hurts in flexion, but it doesn't hurt in rotation. It doesn't hurt in extension. So I know that I can move those muscles of the low back and the spine. We'll just keep it general, but we need to move those areas without pain, preferably. And we still need to get load. We need to get tension. We need to try to make a change to the area that hurts in a non-provocative way. And if we can kind of change the situation where those muscles learn that they have other options, we can start to make a change. And how is it that we can do that? I think that you're totally correct in terms of looking at it with a test and trying to find your inroad. But I do think one thing that if there is something that is missed, it is the built-in capacity. We kind of teased it a little bit earlier, where those PTs are getting some capacity with a bike or whatever, right? But how is it we can find and build in capacity, tension, load into those painful areas? So back to the question, the longest response to a question ever. What does it take to make a change? And I know it depends on person to person. I think that for sure. But where do you find your inroads to make a change?
Yeah, well, I mean, it kind of goes back to, you mentioned, the FMS and Gray Cook and those guys, and they obviously stood on the giants before them, but and then you have people like Kelly Starrett who have taken maybe what Gray has talked about and made it a little bit more user friendly for the general public on things like you were discussing of knowing whether it's something like a fascial type of issue or a muscular type of issue or a joint issue, and then you can make an input based on what you find. That matters because you do kind of want to know what tissue is part of the problem. That changes either the rehab length, the volume, expectations. If it's a mid muscle belly grade 1 or 2 tear, it's going to do a lot better than an enthesopathy or a tear, at the bone, like a high hamstring strain compared to a normal, hamstring strain. That those have poorer outcomes. We know that insertional Achilles tendinopathy has a worse outcome than mid-substance. So these things, and I was also thinking when you were talking about patellar tendinopathy versus maybe the extensor kyphoradialis brevis or tennis elbow type of issues. Some of them, the research kind of shows you should push through pain a bit and kind of load it, and when it stops hurting, well, now you have to hold more weight, so it's actually kind of uncomfortable again. And other ones, it says, do not go into pain. And discs can be thrown in with that type of a topic as well, where, if you're doing an exercise, I don't care if it's McGill's big three that are supposed to be perfect. I know people that cannot do one of McGill's big three, not at all, because of the pain that comes from it. That just means they can't, like a plank, for example, creates compression. Maybe they can't tolerate compression at all, even though they're in neutral spine. So the nuance with the back is, let's get them doing something that, like you said, that doesn't irritate you, so you can get a stimulus, you can get a response, but you're not creating this, like, the inflammatory loop. And we were I was joking when you mentioned you wanted to talk about this, because the answer is always it depends.
Right.
So I'm trying to give some answers, but I think I would want to know a little bit about what I really think the tissue involved is. That helps me.
Mm-hmm.
And sometimes it's multifactorial, right? It's not just a muscle or just a tendon. Usually it's not, but if it's multifactorial, then just understanding where the person's starting from also matters, right? What state are they in? Are they typically somebody that never moves, or this person's in pain because they never know how to take a day off?
Right.
So that, I kind of want to hear, I honestly want to hear your take on that exact question. So I wonder what you'd say to it.
Well, I was thinking, I'm glad that you took a second to respond, because it does depend. And I think I'm always looking for, I won't say tricks, but I'm looking for easier inroads and general principles that will help me.
Why
Because,
easier?
well, easier for patients because of compliance. Easier because I can give you a very complicated exercise, and I'll write you an email. It's like, if I have a patient that needs a very specific and complicated exercise, and I know that it's like, you need to follow the step 1, step 2. This is a cake you're baking, and it is your birthday, and you need to follow this recipe. I'll do that from time to time with a patient, and they'll get a long email, and I know the patient wants to do it, and they'll do it. That's not the majority of the patients I see. I see a good general population. Tomorrow I've got 16 patients, and I cannot do that for each one. It's just not possible. And I'm happy if all 16 patients tomorrow need that, I'll stay extra and I'll do it. But that's is usually not the case anyways. So when I say easy, concepts like your favorite, James Syriac's, I know you like his couple of his techniques, but just his idea of check the joint above and below the site of pain, because oftentimes that is a big window into the system where you can get some movement above and below the joint that hurts, and still affect that area that does hurt. So that's probably my first go-to, is to try to change things above and below, left and right of the area, because it's, I love and hate this statement. It's all connected, you know? And so if I can find some easy ways to not hurt the patient, give them some simple exercises that are indirectly affecting their area of pain, but building a capacity above and below, that would be my answer.
Yeah, I like that. I like it because it's complementary to what I said. It was because what I was saying had nothing to do with that. And that's very true, because I'm thinking, I said, I want to know what tissue it is. That helps me. But I also have to know if that low back pain is because they have terrible hips, and they don't understand their, I don't mean them, but their nervous system does not understand a hinge. They don't understand how to use their body. And I could know exactly what's hurt in the exact location and give it everything I possibly could, and it'll still become a problem because I didn't, for example, I wouldn't have addressed something like the hip or the T-spine or something like that, right? So
Right.
I just, yeah, it's super complimentary, and that stuff matters, because if you have a rate limiting step like a poor hip, well, it doesn't matter how much load you put on the tissue that needs to recover. It'll just be fighting. It's like Sisyphus pushing the boulder up the hill,
Right. 100%. The rate limiting step, you've mentioned that topic a number of times, and I love it. I love it. It's because that's a big inroad too. Absolutely. especially if you have treated, like, your low back hurts, let's say your right QL locks up and it just hurts there from the right SI up to the right TL junction. And we could take all the soft tissue therapy, we can, release those muscles. We could just work that area all around. And sometimes it just pisses it off more. You know what I mean?
Mm.
And so I'm like, we got to find something above and below that area that just indirectly affects it. That's my biggest trick. It's not that big of a trick. Sometimes it's easy to explain to patients, and it's usually something simple that they can do is open up their hip below or open up their ribs above. And that's some classic FMS stuff as well, where you start to go into more global movement patterns. I would say probably that's the next step, getting away from the tissue. Because this is the next problem that the patient has. Every time a patient comes in, they have a symptom. They don't know, they may think they know why it hurts, but that's the main question we doctors, therapists are answering. Why does this hurt? If you aren't getting that question every day, you're not listening. Because, they're like, and this is one thing I was actually talking to another doctor about this week, and I would like to hear what your take on this is, but you know how when you ask patients about if they have old injuries, right? You're like, well, what else has been going on? And a lot of times they'll give you a good answer. A lot of times they're just like, yeah, other stuff, whatever. Which tells me they're really more concerned about that low back. But there are other things that they're like, well, and I'm like, so did you, I would like to know, do you have a new ACL on the left? Do you have a rod going up your right femur? Are you missing a kidney and there are a bunch of scars on your abs? Like, I would like to know these things. But patients, because they have in their mind justified, they're like, well, my knee hurts, but I know why that is, so don't worry about that. Fix my back. I don't know why that's hurting. I need you to figure out why it's hurting. And once I know, then I'll feel better about it. So a lot of the things that we're trying to figure out are not necessarily immediately to give the patient relief. Part of giving them relief is, back to some pain science stuff, helping them understand what's going on. Have you ever seen that, where patients will be like, don't worry about my other injuries?
Yes. Yeah, but I intentionally try to tease those questions out like you're just talking
For
about.
sure.
Because, I know personally how old injuries come back. And that takes us back to the rate limiting step thing. Sometimes it can be an old injury, they didn't tell you that they tore their right groin like many times all through their soccer career. And then you're trying to figure out why they're having a hip problem on one side and not on the other side. And that QL is also a problem. And, it's like that groin is the rate limiting step. That thing is the prevention. And it's not just like joint above and below is great, but there's other rate limiting steps. Like the way that they sit in the same position and play Fortnite for 8 hours a day, or the way that they choose to sleep and breathe. There's so many rate limiting steps. And we've talked about this a little bit, where I say, I am going to lose this battle. There's no amount of exercise. Like, I can give you 10 sets of 50. That's still nothing compared to 8 hours in this position or 25,000 breaths a day. So a good takeaway would be trying to say, if you've never thought, what's the rate limiting step for this patient? That would be a good way to start thinking about this for rehab too, or just the recovery of the person. Because it'll say, okay, what's the rate limiting step? That doesn't mean what is causing my pain. You're saying what is preventing them from getting out of pain, which is a better question than what is hurting or why am I hurting?
No, 100%, man. There are so many times I've been so frustrated. This is the worst thing for me. Patient comes in, I work on them. They leave my office, they go, feeling better. Thanks, doc. Really appreciate it. I am going to send my friends to come see you. Come back the next time. 2 days later, it came back. I just need your magic hands to kind of fix me up again. And I go, dude, and thank you. I'm glad. I don't want to, I want to fix this and get this done. I want this to be over with. I don't want you to I don't want a revolving door of you. I love talking to you, patient. I really do want to hear your opinions on global politics. But I want to fix your back and I want to get you out into life and be self-sustainable. So anytime that happens, I imagine my treatment was good and I don't abandon that right away. I know that I probably need to do the same thing that I did before. And then I need to find what that rate limiting step is. What is the thing that is winding you back up? Are you sleeping in a position where you're breathing yourself back into this? Or are your shoes worn in such a way? Are you wearing your shoes in such a way that your every step you take is winding up your knee pain? What is that other thing? So we need to discuss, if we couldn't dig into it enough, your old kind of injuries. And so that will be the big, and they're like, well, I've sprained my ankle 1,000 times. I play college soccer. My ankle's been sprained a bunch of times. If I can kind of just generally keep that ankle in check, a lot of things get better with my body. I think that's that your rate limiting step. There's got to be a nicer way to say it. What's your other biggest hiccup? But I think that's a really easy kind of road into making a lasting change. So if I'm going to give rehab for somebody, let's go back to what rehab will make a change. I'm going to give something specific to that area for the patient, because if a patient's back hurts, you have to do something for their back. Now, the second thing I would do, if you're going to give them, you're going to blast out a bunch of injuries, I'm going to give them something nice and easy for their secondary, or perhaps, honestly, it might even be a primary injury. So to make a change in rehab, joint above and below, something direct, above or below, and then for sure, if it's that clear, that rate limiting step I'm going after. Strategy de Cybulski. But yeah.
Right. I do think there's, I agree with all that. I would be something very similar. But I do think I could still put people in these kind of categories of rehab where, if you look at somebody, some are very obviously, at least in the immediate future, they need something closer to the idea from FR, like force is the language of cells. So whether that is some type of joint rotations because they need to improve something, or force is the language of cells, the only way that you get through this Achilles or this tendon problem is loading, that you have to go that way. You have to get some loading in there. And if you don't know what to do, just look up the most recent guidelines on patellar tendinopathy, or follow a few people on Twitter that study this stuff and throw that at them, right? So at least you're getting load in there. But then there's some things that are not directly treated by just forces the language of cells, in a way. Some things are patternized, neurological. So that I would just say there's groups that I could put people into. And then maybe, once they have enough load, you can work on these things simultaneously. But let's say the tendon problem is getting better in that knee, but then you can start to switch into say, okay, why was it the left knee and not the right knee? If there was no obvious reason, then there's probably a neurological or patterned reason why it was the left and not the right. And then you still have to, that's where joint above and below, does the joint behave like a joint? These kind of things, which would clear out that rate limiting step for the return of the injury that they had, right? So I'm just saying, you can I categorize people sometimes as I see them mentally based on their presentation and their story. And I do think, 3 hours sounds ridiculous, but I do think the more time we ask good questions, we probably could solve so many. Even me and you, and people been doing this much longer than us, asking better questions sometimes get you there. You never asked, did you have any terrible injuries in the past? Do you have, what are your ADLs like? What do you do for your hobbies? Weird questions like vision questions or whatever it is you want to get into, where all of a sudden they just, by asking the right question, they just tied everything together for you. And I do think that that's something, I think everybody could work on, is just asking better questions.
Yeah.
And that'll help us guide the rehab right there.
Absolutely. Some of you listening to some of those answers, they'll guide you to some of those things. I do think, we'll wrap this up here pretty soon, but I do I think the last phase is something you kind of touched on. I still want to hear your opinion a little bit more on it to dig into it, because so again, back to the language of how you understand things and broadening that. We've gone from tight, we've gone weak, sharp pain. Let's just stick to the muscles. I can't move well, I just feel stiff, right? To compression, extension, torsion, global. Is it a joint thing? Is it a neuromuscular stiffness thing? So we can start to group it in that sense in terms of going back to the rehab. But then there are, okay, so we've activated a glute, right? Whatever that really means. We've activated a glute on the side. We can perhaps even do it with our feet on the ground. We talked a little bit about this in our the sports physio episode, bridging the gap to rehab one. That's a great one. You should check it out. But some of these extra categories that get make the rehab that makes a change. Once you start to use a muscle, how much does it take to keep that strength in the glute? Where it is applicable to get right glute strength enough such that you don't have to use your right QL as much as you would use your right glute. So in terms of building in capacity, building in tension and load in different movement and different planes. So this is back to your neuromuscular thing. We're talking about different patterns. To keep it simple, it would be like a half kneeling pattern versus laying on the side versus laying on the right side, left side, prone, a bird dog thing, a kneeling position. The DNS people will go into specific months of development where you would see someone kind of like your post was doing a side plank, right? That's kind of a developmental pattern of rolling where you're starting to get some transverse movement in there. So you could find and activate, say, the right glute. Let's just stick with this right glute, right QL example, from the ground up, from a supine, from a prone, from a side lying. And then when you're up on the feet, this is where you get to see the sports physio stuff towards the end, where he's incorporating that with a larger movement pattern with some speed and dynamic stuff, which is kind of what you were getting at, I believe, is once you can activate that glute, can you activate it actively in life, walking down the hall, turning at the grocery store? And so building in let's just start over, joint capacity. Do you have the orthopedic baselines, right? Can you access a muscle in and of it by itself? Can you use that joint and that muscle in continually harder and progressive positions from the bottom, supine, prone, kneeling, to upright? And then can you use that muscle and joint through continuing capacity and tension and load, which ultimately comes up to some speed and stuff? That is not a thorough rehab program. That is my one shot at it. Does that make sense? What did I miss?
No, I think you just laid it all out right there. I think it was supposed to be a question, but then you perfectly just kind of iterated what the kind of a thought process would look like from the beginning towards the end of rehab. I don't know. I think you did really well there.
Oh, thanks, man. I accidentally slipped on that. The coffee is just pumping right now, bro.
Poured out of your subconsciousness, and you nailed it.
Every question that I ask is a question I have, but going back to, like, I have that in my head. I can't do that for every patient. I wish that I could, I honestly, 3 hours is probably too much. Maybe an hour and a half, 2 hours with a patient, give or take, to do the work I need to do. I can get through a bunch of stuff. You don't have to get all the way upright and be like the Tampa Bay Buccaneers, third round draft pick running back and do those exercises that Zach, the sports physio, has them doing. A lot of times you can get somebody relief, back to what I was saying, in the easiest way possible, joint above and below, or like Bobby said, find the rate limiting step and just make enough of an impact with those inroads to change the person's day to day. I think that is probably the first way I would go.
Yeah.
Would you agree?
Yeah, and knowing, the patient's needs and goals means you understand the capacity requirements of that individual. So I mean, it's great working with professional athletes, but you have to go to, the end of that pyramid that John just laid out to make sure that they're okay in their sport, because their capacity needs are so high that they have to be able to integrate all that activity all at once and not get injured and not re-irritate their glute med or whatever's mad at them, because of the demands of their sport or their activities are so high. So it's great to work with them, but your job is harder. If you just need to get somebody not to have back pain when they, work at the bank or whatever they do, the capacity demands for them are only so high. You do not need to train them to be able to do, heavy banded lateral hops and land on a Bosu ball. They will never do that in life anyway. So they need to be able to walk, stand, pick things up, get in a car, get out, maybe tolerate sitting for long periods because it's
Mhm.
2020. Maybe, you know what I mean? Like that's what they need to do. So
Yeah.
your pyramid stops once you're above the threshold of their demands,
Yeah.
for the most part. For the most part. And then, and that's part of the problem is so many people are operating briefly so much over their own threshold, but pre-pain, they're they're pre-injury, but the pain's not there yet. They're operating like they're going to CrossFit, and they're also a carpenter, and they're subclinical for a while until all these apathies and itises kick in, because they never could tolerate that load long term anyway. So
Right.
I'm just saying, knowing the person in front of you dictates how far you need to go down that rabbit hole of rehab. And I do think for most of those middle of the road people, I think these rate limiting steps of the problems that they have, many of their problems, they don't whisper, they scream. And what that means is if you got 43 degrees of IR on the right and 46 on the left, you don't need to probably balance out their IR. What you'll notice is they can do a single leg bridge on a ball, no problem on one side, and they can't do it on the ground for 10 seconds, and they're shaking with the other leg. And that's what I mean by screaming. A lot of these things are blatantly obvious, but if you never were to test them, you'd never find them. So you got a hip, or to go back to a joint, you have a hip that goes 40 degrees IR and 80 degrees ER, and then you go to the other side and it has 5 degrees of internal rotation. Okay, you have a screaming discrepancy. And that's what I mean by patients don't whisper usually, they usually yell, but you have to find where they're screaming from, um, most of the time. Most of the time.
No,
Yeah.
I think you laid it out perfectly there, um, and I think that's a really good place to stop. There's a bunch of gems in this one, man. I didn't know where when we started, and this is most episodes. I don't know where they're gonna go, but I feel really good about it. I think one final thing, just to kind of wrap things up, asking good questions, thinking about precisely what it is you want to accomplish with the patient versus what it is they need as well,
Mhm.
finding the rate limiting step, finding some easier inroads that will help them, do things on their own to increase compliance. My last thing I would say is I would just challenge therapists out there to try to simplify what they're doing to meet the requirements of the patient in front of them, to do things more concisely, maybe to ask a few questions or do a couple extra tests to figure out what it is they're doing and why they're doing it. Kind of like Bobby was saying, if you throw 1,000 things at it and it fixes the problem, you don't know which one of those things did it. The better you get at your job, and the happier you'll be, is when you know what you're doing and why it works and why you can help. And if you continue to refine that slowly, it takes time, but if you can just kind of refine that slowly, I would just kind of challenge listeners to do that, and you'll enjoy your work a little bit more, I think. Anything to polish this one off, Bobby?
No, I would just add that simplify, but base that simplification off of the the specificity that you've gained by asking better questions or
Yeah.
by doing more tests. So you realize, okay, this joint is not doing well. Then you can add something basic. Like, you don't have to give them 5 things. Just start working on that joint. So it's simple, but it's based off of the complexity of the specifics based on that individual in front of you.
I appreciate you cleaning up my mess, and we'll do this next week. Same time, same place. Thank y'all for listening. Later.